it's time to get started. Welcome everyone for this webinar about the management of heavy menstruation bleeding. This webinar is done instead of the second European conference about women and bleeding disorder, which was due this month, but due to the circumstances, we obviously had to change the plans. And we hope to have this grand conference next year in May 2021. But first of all, I would like to thank all our sponsors, Bayer, CSL Behring, Novo Nordisk, and Takeda for supporting this event, despite this current change of format. I would also really like to thank all our speakers for agreeing to this change of format at such a short notice. And before we get started with the more content-wise, I just want to introduce myself. My name is Naja Skouw-Rasmussen. I'm a steering committee member at the European Hemophilia Consortium, but I'm also happily chairing the EHC Women and Bleeding Disorder Committee, who is driving this webinar and driving this agenda about women and bleeding disorder at EHC. But let's get started on the more content-wise and the most exciting things that we are here for. Actually, today is International Menstrual Hygiene Day, and what better way is to host a webinar about heavy menstruational bleeding. This is an issue affecting many women with a bleeding disorder, and it has a considerable impact on their daily life and in general, their quality of life. As many as 1/3 of women with heavy menstrual bleed actually have an underlying bleeding disorder. So it's an issue that is affecting a lot of people. We also saw in a recent European Hemophilia Consortium survey that women who have a bleeding disorder report heavy menstrual bleeding as one of the major impacts on their daily life. But to enlighten us about this very crucial bloody issue, we are very lucky to have Dr. Rezan Kadir, Dr. Thynn and nurse Malin Svennefalk on board to be presenting and available for questions throughout this webinar. So our first speaker is Dr. Rezan Kadir, who is a consultant obstetrician and gynecologist from the Royal Free Hospital in London, UK. She has a long and impressive record in the field of gynecology and obstetrics for women with bleeding disorder. And Dr. Kadir has set up a multidisciplinary clinic in the Hemophilia Center in London, and she's also chairing the Women Bleed 2 board at the UK Hemophilia Society. And she's produced numerous of publications and research in this field that I can only recommend you to look for. Dr. Kadir will give us some insight in the menstrual cycle and how it's impacted by issues in coagulation. Please, Dr. Kadir, the screen is yours.
Thank you very much, Naya, for the introduction, and good morning, good afternoon, good evening, wherever you are. So I'm going to talk about menstruation and menstrual cycle, what is normal, and how are the changes happen throughout the reproductive life, and how this and why it might be different in women with bleeding disorders. So let's talk about menarche first. We know menarche is the start of menstruation, is the first menstruation that happens in a young girl, and really it signals a start of a teamwork or a interplay synchronized between the two important organs, hypothalamus and the pituitary in the brain, and also the ovaries, which is important female organ. And this work will lead to the cyclical release of two hormones which are fundamental in women, estrogen and progesterone. And the age of menarche is around 11 in average age in Caucasian, but varies anywhere between 9 to 16 depending on the race, culture, or other factors. So when this cyclical release of hormones happen, we have menstrual cycle. This is a typical cycle, which is 28-day cycle. At the beginning of the cycle, which we call it follicular phase, we can see that the pituitary releases a hormone called follicular stimulating hormone that will lead to maturation of the follicle in the ovary, preparing for ovulation. While the follicles are maturing, estrogen is secreted from these follicles and impacts on the uterus, but mainly the endometrium, and start regenerating endometrium because it has already been shed from the previous menstruation. In about 14 days, which is a mid-cycle, ovulation occurs. When ovulation occurs, the ova is released and the follicle becomes a structure we call corpus luteum, and that secretes two hormones, estrogen and progesterone, but mainly progesterone, and that prepares the endometrium for implantation of the ovum that has already been released. But if the implantation does not occur, then the corpus luteum shrinks and the menstruation happens. But we know that not every menstrual cycle is 28 days, not always ovulation happens at 14 days. And in this study, you can see 167 women in the peak of their reproductive life were assessed. The study shows that the normal menstrual cycle could range between 23 to 32 days, and ovulation can occur anywhere between day 12 to 17. And even in the same women, there is a variation or difference from one cycle to another. In this graph, as you can see, that is one woman, they followed for 8 cycles, and you can see there is a difference of 1 or 2 days in her menstrual length, and ovulation occurred 1 or 2 days difference around day 14. The studies also show that not every cycle women has ovulation. And this is a large population study from Norway. Over 1,000 women were followed, and they did a test, which is a progesterone test, in the second part after ovulation as a surrogate for checking ovulation. And we can see that about 1/3 of the women were not ovulating. And we can see also here the range of age of women were between 20 to 49 years. And it is obvious that the older the woman is, the less likely is her cycle is ovulatory. So what happens if ovulation does not occur? Well, if no ovulation, the corpus, the follicle keep secreting estrogen. The corpus luteum is not formed, there is no progesterone, and the estrogen increases the thickness and the growing of the endometrium continuously until it cannot maintain itself, but is not stabilized because there is no progesterone, and starts shedding. And that leads to all sorts of irregular heavy periods, late period, heavy menstruation, spotting before and after the period. In the years leading to after the menarche, which are the adolescent periods, the ovary is not mature and is maturing, and therefore the young girl is more likely to have an ovulation. And these two studies in these graphs, you can see that girls, sorry about that, girls in their first 5 years after menstruation, which we call them gynecologic year, most likely were anovulatory. And apart from age, other factors affect how frequent these young girls ovulate: their weight, their ethnicity, the amount of exercise. They have other problems such as polycystic ovaries. But it is important for us, for everybody, to know what is normal for these girls and when to seek help. This criteria was put by the American College of Obstetrician Gynecologists, where they showed that a menstrual cycle interval anywhere between 21 to 45 days, it is acceptable for young girls. Menstruation 7 days, or should be 7 days or less, and the menstrual product use or sanitary towels or protection up to 6 a day. Beyond that, it is important that the girl or her family is alert to seek help to avoid anemia and impact on her health and quality of life and schooling. Similarly, the years that leading to menopause, the ovary is aging, and there is decreasingly less ovulation during the cycle, and there is a drop in the amount of estrogen secreted, until the menopause happens, which is usually average age of 51. And this is the last menstruation, and beyond that, after 12 months, we call the woman post-menopausal. So this period of perimenopause, where it's leading to menopause and around it, it could last anywhere between 3 to 10 years. And the woman at this stage not only has infrequent ovulation during her menstrual cycle, but she could also have a premature ovulation, i.e. ovulation happens when the follicle is not mature, so the progesterone amount that she's secreting is less, there is dominance of estrogen, the endometrium gets thickened and also becomes irregularly shedding, leading to all sorts of abnormal bleeding problems. Not only that, sometimes it could lead to thickening and hyperplasias that could be pre-malignant or even malignant changes. As it happens, around the same time or the same age, the women increasingly have benign pathologies of pelvic organ, such as fibroid and polyp, and these will all lead to abnormal menstruation and bleeding. So menopause usually hits around an average age of 51, but of course this varies as well. And this is due to estrogen insufficiency and leads to all sorts of variety of the symptoms that have been reported by women. But menopause really has a big impact of women herself and the whole society. Women nowadays live 1/3 of their life postmenopausal. This data from UK show that 13 million women in UK has reached menopause. 1 in 4 of them suffered symptoms that bad enough to affect their quality of life. And 10%, even after 15 years, they suffer these symptoms. And you can see the list of symptoms here, long list, but really there are 4 core symptoms that has been really linked to estrogen insufficiency, which are the vasomotor symptoms, hot flushes and sweating, night sweating, urogenital symptom, mainly dryness in the vagina and painful intercourse, and sleep problems, as well as mood changes and depression. In addition to that, there is health issues that estrogen deficiency lead into increased cardiovascular risk, decreased bone density, and increased risk of fracture in women after menopause. So now let's see how these changes may affect women with bleeding disorders. Well, we know that women are more likely to suffer bleeding symptoms when they are affected with any bleeding disorder, and this data is from World Federation of Hemophilia Global Survey, the last one. They showed that almost every bleeding disorder, there's a predominance of women, especially platelet function defect and von Willebrand disease, and this is simply because women are subjected to the hemostatic challenge every month, twice, during the menstruation and ovulation. And because of this challenge and because their coagulation defect, they are subjected to different bleeding problems during these processes. Of course, menstruation and ovulation are tissue injury. Similar to any tissue injury, we need hemostasis, intact hemostasis to stop bleeding. And intact hemostasis need 3 processes. First, the vessels around the injury to narrow, to slow down the blood flow around the injury. Then the platelets start to clump together and stick to the vessel wall to close the hole. Then von Willebrand factor is released from the platelet or the vessel wall to adhere these platelets to the wall and to each other. And finally, clotting factors get activated and makes a fibrin mesh between the platelet and the vessel wall, and sealing the hole in the vessel and stopping the bleeding. Of course, if you have deficiency in any of these factors, there will be abnormal bleeding, prolonged bleeding, and heavy bleeding. So it is not surprising that women with bleeding disorder may suffer menstrual problems and abnormal bleeding throughout their menstrual reproductive life, but more so during the change around adolescence and perimenopause because of the abnormalities in the ovulation and the abnormal growing of the endometrium. And of course, if she has any other gynecological problem, and that all these abnormalities will impact her health and quality of life. As Naja said, the commonest bleeding symptom in women is heavy menstrual bleeding, and this is data from Royal Free Hour Center, and others show that 50 to 75% of women with bleeding disorder suffer heavy menstrual bleeding from menarche from the start to menopause. Similarly, when ovulation happens, there is a tissue injury here as the ova is released, but in normally there's a very little bleeding or nothing, and women sometimes do feel a bit of pain mid-cycle. We call it Mittelschmerz pain or mid-cycle pain. But if a woman has a bleeding disorder, this bleeding may continue for longer, and often we see our women with bleeding disorder describe 2 to 3 days of significant pain around the time of ovulation. If the bleeding hits an area where there's a big vessel, or the woman has a very severe bleeding disorder, indeed girls mostly, such as Glanzmann thrombocytopenia, would lead to a hemorrhage, which will be leading to blood in the abdominal cavity, hematomas in the surrounding organ, or blood into the ovary, causing large hemorrhagic cysts. And this occurs in about 8 to 10% of women with bleeding disorder, often need urgent medical intervention. So I just wanted to share this ultrasound picture of one of our young girls that me and Dr. Yi manage. She has a severe type of von Willebrand disease, and against advice, she stopped her pill, and then she attended with severe pain. And you can see both her ovaries have large hemorrhage due to ovulation bleeding. What about endometriosis? Well, endometriosis is a common gynecological problem and affects 10% of women. It's a chronic condition, leads to abnormal bleedings and pain and fertility issues. And you can see here, this woman with endometriosis, there's a hemorrhagic type of cyst, which is called chocolate cyst or endometrioma. And we call it chocolate cyst because the bleeding is old and becomes brown in color like a melted chocolate, and it has significant impact on quality of life of women. We don't really know why endometriosis occurs in some women, but one of the theories is that if a woman bleeds very heavily, instead of the blood coming out of the vagina, some of it goes backward through the tube and get the endometrium that's shedding get implanted in the ovary or the surrounding organ. And you can see here, and this endometrium is active, and every menstrual cycle gets activated and bleeds with the menstruation and leads to these complications. And because women with bleeding disorders have heavy menstruation, they are more likely to suffer endometriosis and the symptoms of endometriosis. This is an old study from United States showed that women with von Willebrand disease are much more likely to suffer or report endometriosis than general population. So all these abnormal menstrual bleeding symptoms, of course, has big impact on women from health issues, iron deficiency, all type of pain, needing hospitalization, unnecessary intervention. Even some of them end up with hysterectomy very early because we have not made diagnosis. Of course, affect quality of life with adverse psychosocial impact on their school and work and career advancement. Naya mentioned this survey that we did last year through the European Hemophilia Consortium, and the women clearly showed that having a bleeding disorder has an important impact on their physical, romantic, social, active, and reproductive life. And indeed, having menstrual bleeding is the commonest symptom with the biggest impact reported by 55% of women. And there is really drastic comments by these women how this bleeding affect them. Unfortunately, I don't have time to read through them. So it is important to know how to improve care of girls and women with bleeding disorder and with these menstrual problems. And over the last 20 years, a lot has been done into acknowledging menstrual problem in women and girls with bleeding disorders, but there's a lot more to do, and it's responsibility of all of us, clinicians, medical societies, as well as patient organization through education, advocacy program, and most importantly, in my view, is bringing together women and healthcare professionals so that we understand the priorities and improve awareness and diagnosis of these women. At a local level, all women with bleeding disorder should have access to hemophilia treatment center and a gynecological obstetric service, and preferably joint clinics. There should be really clear pathways from the services on how to diagnose women and manage women with bleeding disorder and gynecological problem. And the care of these women should go beyond the hospital into their home, school, and workplace, and that's how we can improve their quality of life. We really have to be proactive and anticipate and prepare, especially at the time of change. For example, adolescents and perimenopause, we should counsel them upfront what a problem, menstrual problem or otherwise they could face, encourage them to use of simple tools such as menstrual chart to highlight for those who are having abnormality to seek help early. We must always make sure that they have optimal hemoglobin and iron stores to minimize the impact of anemia on their quality, the amount of bleeding they are having. In adolescents, for example, we have to prepare and provide treatment from the first period, for example, tranexamic acid. Sometimes when a girl has a very severe bleeding symptoms such as glandular thrombosthenia, we even start hormonal therapy before the menarche to prevent hemorrhage during the first period. Similarly, around the perimenopause and menopause, we should counsel the women about menstrual and menopausal symptoms and advise them lifestyle and other changes, how to manage these symptoms, and also have a close collaboration with the gynecology team so that we don't miss or delay diagnosis of a gynecological problem that is treatable. And this can only be achieved through multidisciplinary management and individualized approach that are which is vital to improve quality of care. And this is done by collaboration between all the clinicians, with the patient being in the center of the team and decision making, so that we provide a care that is suitable and individualized to her. Well, we know that bleeding disorders are not curable, but gynecological problems can be prevented and can be treated, and there are a variety of hormonal, hemostatic, and surgical treatment. We will have some opportunity to discuss them later during our case discussions that can be done for these women to minimize or treat their gynecological or menstrual issues. So I can conclude now that women with bleeding disorder suffer significant menstrual symptoms and bleeding symptoms during reproductive life and even beyond menopause that really has impact on quality of life. But there are preventative measures, treatment for these gynecological problems. But first we have to establish diagnosis. Education, research, and international collaboration are very important to increase awareness and improve diagnosis of these women. And also access to hemophilia treatment center and multidisciplinary approach is also vital to improve care and quality of life for these women. And with that, I will finish. Thank you very much.
Thank you very much, Dr. Kadir, for this very extensive and very fast presentation of some of the issues that the women are suffering from and the menstrual cycle, how it actually works. I would like to introduce our next speaker, Dr. Yi, who is a very passionate hematologist who works at the International Hemophilia Training Centre, also based at the Royal Free Hospital in London, UK. Dr. Yi has been working hard for many, many years and also been very eager to close the gap in the hemophilia care, and therefore she's also leading a twinning project with the hematology department in Myanmar. Dr. Yi will introduce us to some of the hemostasis impacts on menstruation, and she will also give us some insight by using 3 case studies on how to manage periods. The floor is yours, Dr. Yi.
Thank you. So, hello everyone, and welcome to this European conference virtually. So, I'm a hematologist, and I've been working in the Hemophilia Center for a long time. So, I just want to touch a few things on hemostasis impact on menstruation, and I'm not going to overlap some of the slides that Rezan has already mentioned. So the next slide, please. Oh, we all know that the endometrium has 2 layers before the menstruation with the hormonal. They get expanded and vascularized. And when you menstruate, these vessels and the cells are sloughed off. Next slide, please. So basically, we've gone through this. So what I think I'll just go on to the next slide. where I want to say that vasoconstriction is also important because that has not been mentioned earlier on. And I see a lot of young ladies in my clinic coming in with heavy periods and easy bruising. And we do a lot of investigations and do not find anything, but I'm now used to them. So what I ask them is, do you have joints that are very hypermobile and your skin is very thin and very elastic? And they do have this. So hypermobile joints giving rise to that they can't sort of like have a good vasoconstriction can also contribute towards heavy periods. Next slide, please. So some of the, so I'm just trying to point out a few things that have not been mentioned. You have to remember hypermobility syndrome, which is a vast, has a vast spectrum. And at the other end is this Ehlers-Danlos syndrome, where the connective tissue of the blood vessels is weak. And so therefore the vasoconstriction cannot happen. And also the platelet disorders, when you have increased platelet destruction or bone marrow production is reduced, or the platelet number is all right, but they are not functioning, such as Glanzmann syndrome, or when you have storage food disorders, when there are no granules, chemicals inside the platelets. Next slide, please. So some of the bleeding disorders, Rezan has mentioned the other rare bleeding disorders. I just want to tell you about carriers of hemophilia A and B. Now, 30% of carriers can have low factor levels, factor 8 or 9 levels, and they can be symptomatic. And the reason for this low level is because there is this normal physiological process in the body called lionization of the X chromosome, which is an inactivation of the X chromosome. This is a random process, so we do not know which X is going to be inactivated. So if the X with the no gene mutation has been inactivated, the one with the gene mutation is left to cope, so therefore they can have low levels. Next slide, please. So when you see patients with heavy periods, and you consider whether they have an underlying bleeding disorder, you need to ask a few questions that are important. So the questions that you have to ask are, do you have any past bleeding problems? And when you have had trauma, surgery, cuts, what sort of, when you have had challenge to your hemostasis system, how do you respond? That is important. And for female, you have to ask if they have had persistent menorrhagia, postpartum hemorrhage, or pregnancy losses even. Next slide, please. And of course, drug history is also important. Sometimes patient on anticoagulation and other medical disorders. Next slide, please. And a bleeding score is very important. So we use bleeding scores, and if the bleeding score for a woman is more than 5 or equal to 5, then we undertake more investigations towards whether they have an underlying bleeding disorder or not. Next slide, please. So it's important that good history taking, bleeding score, investigations, and if we can identify an underlying bleeding disorder, then we can treat it, and it has a major impact on their heavy periods because we can give them appropriate therapy. And I have to say that this joint clinical service between a hematologist and obstetrician is a key factor in this care for a woman with bleeding disorder. And I've been in this center. Rezan and I came, we were together as registrars, and that is 25 years ago. And since then, this joint clinic has been set up. So it's a long history for us, and we've seen the good value of this that we can give to our patients. Next slide, please. So now I would like to go on to share some of the patient stories that we have seen in these clinics. So this is a story about teenage twins with heavy periods. Next slide, please. So they are now 17 years old, but they were born in Pakistan. And they had nosebleeds as when they were growing up, and after dental extraction, they bled. Their parents are first cousins. So in countries where there is this sort of consanguineous marriages, we have to be very careful and try to find out if they have an underlying autosomal recessive rare bleeding disorders. So in Pakistan, the diagnosis was made. The clinicians there were very good because first coagulation screen and platelet count were normal. And at that point, they could be easily ignored. But some specialized tests were undertaken, such as platelet aggregation and flow cytometry, to clinch the diagnosis of Glanzmann syndrome. So next slide, please. This is a functional platelet disorder where you can get nosebleeds from a young age, oral cavity bleeding, bruising, purpura, and heavy periods, of course, for a woman, and bleeding after surgery, injury, and childbirth. Next slide, please. So basically what it is that the platelet, for them to stick to one another and for them to stick to von Willebrand and also stick to the vascular endothelium, they have these glycoprotein receptors on their surface. And the glycoprotein 2B3A, which sticks to the fibrinogen, which is the clotting factor number 1, is lacking in Glanzmann. So as you can see in these cartoons, the sticking of the platelets. Next slide, please. So this was identified in children from a village in the Swiss Alps since 1918. And since then, it has been identified in many populations around the world. It's autosomal recessive, and it is on the chromosome 17. And the prevalence, as you can see. Next slide, please. So this is just showing you a diagram of autosomal recessive inheritance. In the family that I've said, the parents are cousins and they both carry. So 1 in 4 offspring can be affected. So the twins, unfortunately, were affected. They have a younger brother who is not affected. Next slide, please. So in the management of heavy periods, antifibrinolytic agents are very important. Whether they have an underlying bleeding disorder or not, antifibrinolytic agents such as tranexamic acid or aminocapric acid, these are very, very important therapeutic agents because they work, they are efficient, they do not have lots of side effects, and they are cheap. And then the other thing is you must make sure that patients are on iron supplements, because if you are anemic, it affects your quality of life, as well as when you have anemia, you bleed more. And then starting oral contraceptive pills, especially in young girls, is a bit of an issue. So you sometimes have to talk with the parents. So that bit, I'll leave it to Rezan for later. And I think the reason for oral contraceptive pills is of two-fold as well, because we want to prevent ovulation, sometimes as stated earlier on, that you can get this bleeding into the ovary when you ovulate. Very important, as a child is growing up in school, they have lots of issues, so psychological support is very important. And of course, specific management of each bleeding disorder. In this case, for Glanzmann, either platelets or recombinant 7A may be used. Next slide, please. So I think we're going to have discussion after all the cases have been discussed. So this is another patient. I've labeled it honeymoon disaster. Next slide, please. So what is it? Is this lady comes from Libya. She born in 1987. She has had dental extraction, post-dental extraction, bleeding, heavy periods, and she was diagnosed with von Willebrand. In Egypt, they went from Libya to Egypt and they got the diagnosis. Now, she came over to UK in 2016 as part of arranged marriage. And she had her honeymoon in Turkey, and there was disaster on that day. And she had to be hospitalized in Turkey for serious bleeding requiring blood transfusion. I saw her later on when she had returned from her honeymoon, and she has been diagnosed with type 3 von Willebrand disorder and registered in our center now. Next slide, please. So, is that the one, or is there another slide in between? Or okay. So I think I wanted to just highlight a few things. There are some psychosocial issues. I've seen women coming from different regions, and they don't talk about, about heavy periods because they would sometimes tell me that their mother had it as well, or their older sister had it. And they all consider this is a normal thing. So they don't come out very early on thinking that their heavy periods is just a normal thing. So, and there's no openness about discussing about menstruation within family members, amongst friends, and in relationships. These are some of the things that I always hear when I see patients, that they come late in diagnosis, and when I ask them why is it that you haven't come up early on, these are the sort of things they would tell me. And also, they have difficulty in talking about underlying bleeding disorders because of marriageability issues, so they hide these things. Next slide, please. So it's when this lady came to our, this lady who had a honeymoon disaster after diagnosing for one-way brand, it was very important for us to educate the patient and her husband on the bleeding disorder and how best to manage. And we started her on prophylaxis. As I said, she's got type 3, she has severe menorrhagia, she's anemic. So our nurses have to assess venous access and training of the patient and the partner for clotting factor infusion on their own at home. So home delivery is discussed, and also keeping diary of bleeds. So we have this system in the UK called HemeTrack. Next slide, please. So now the family wants to start a family. So she had difficulty in conceiving, so I've referred her to infertility unit. So we have to think about managing the hormone therapy for ovulation, and during retrieval of eggs, we need to cover her with clotting factor. Next slide. And also, hemostasis is important in the embedment of the fertilized ovum. Okay, the last case is an inherited bleeding disorder that can cause both bleeding and clotting. So this is very recent. Next slide, please. A lady born in 1988. She was diagnosed at the age of 13 years because she had poor wound healing after foot operation. So her initial test showed she had a prolonged thrombin time and rupturase time, and further investigations show that fibrinogen activity and antigen, there was a discrepancy. So this is diagnosed as dysfibrinogenemia. And in the family, father and older sister also have it, and we have confirmed with the genetics. Next slide, please. So, and the father has the dysfibrinogenemia, but the mother has also hypermobile joints. So this is the hypermobile joints I wanted to illustrate on these photos. So some of these young ladies, I've seen a lot now, these hypermobile joints, and they come in with these easy bruising, as you can see. Next slide, please. So she just delivered her baby last week, and its dysfibrinogenemia is autosomal dominant, so 50% of babies can be affected, surgery and trauma related bleeding. So, and certain mutations can cause thrombosis as well. So she had clotting factor concentric replacement for the vaginal delivery, antifibrinolytics essential. So during delivery, we try to prevent prolonged labor, active management of third stage of labor. Next slide, please. And also cautions for the newborn, such as we always try to prevent high forceps. We do not allow actually ventouse delivery, skull blood sampling, and vitamin K to be given by orally rather than injection. And because the baby is born here, we can do cord blood assessment and we can give the diagnosis straight away as it is autosomal dominant. I think that's the last of my slide. And thank you very much for listening to these. And we can sort of like discuss if there are any questions on.
Thank you very much, Dr. Yi, for your presentation and taking us through some of these different case studies and different cases that you've been experiencing. We are just going to have a short question and answer session before moving on. And I can see quite a few questions are already popping in. But I would like to start with a question for Dr. Kadir. We got a question about would treatment for heavy menstrual bleeding in women with bleeding disorder reduce the incidence of women developing endometriosis? And if so, what is the impact of it?
So that's a good question, but there is no evidence that it will reduce incidence of endometriosis, neither in women with bleeding disorder nor in a normal population. There has not been any study, but of course it is important to reduce menstrual blood flow for all other reasons, because it causes anemia and affects quality of life. But whether it will reduce the incidence of endometriosis, that is really unknown.
Dr. Yi, maybe with the patients you've seen, what kind of tools do you use for the patients so they can see and you can assess how much bleeding do they have through the menstruation?
I think Rezan would be the best to answer, because we have this pictorial menstrual bleeding card. So for myself, I would do the bleeding score, which I have shown earlier on. But there's a pictorial menstrual card that Rezan, again, I think would be the best to talk about.
So if I may, yes, I agree with Dr. Yi. It's the menstrual chart that we use, not only menstrual chart, menstrual diary, to see the frequency of menstruation and the chart, and we teach them to score their menstruation, how many days, what amount of the sanitary towel and pads they used, how soaked it was, and we have a calculated score, which sometimes the ladies themselves can do it, or we can do it for them. And the other tool we also use, very simple, checking their hemoglobin and iron stores, because eventually increased menstrual blood loss lead to anemia. We can also monitor treatment based on these parameters.
Okay, thank you very much. And maybe another question for you, Dr. Kadir. You mentioned that when we talk about the care for women, that we should extend it to also be at their home and at their work. Do you have any suggestions about how we could extend that care for women with bleeding disorders to their home and work?
Yeah, that is very important part of care, especially for young girls. And which with that I meant that engaging the family, educating the family, not only for the young girl, because these are also inherited bleeding disorders, so that we screen the rest. And also sometimes we need to go and teach mothers and teach the girls themselves how to maybe inject their clotting factor if clotting factor needed, educate the school about the need of the girl, why she couldn't do sport, for example. And we have girls where they were punished because they could not do sport, and nobody in the school understood that they have a severe bleeding problem, or they could not understand why the girl keep going out of class because she was bleeding so heavily she needed to go to toilet. So there are simple measures, and it impacts really the quality of life. And if you have a multidisciplinary care, then we can extend the care and improve their quality of life that way.
I think I just mentioned in my slide as well, the openness about discussing this menstruation within family and friends is very important. So I think that is key. So because patients do come in saying that my mother has bled, but I thought my bleeding is normal as well. And that sort of discussion, that this is not normal, they need to be educated. So I don't know whether like the nursing staff and the family therapists can sort of like expand this education for the whole family.
Thank you. We have another question when it comes to hormone treatment. If you, as a young girl, has had hormone age of 11, 12 years old to manage her factor deficiency and to manage her periods, is there any experience in the long-term effects on the women's health when you start hormone treatment in a very early age? Do we have any study, any data, and what is the experiences you have from your respective clinics? Maybe Dr. Yi, you would start, and then Dr. Kadir could follow up.
Yes, so we always start with antifibrinolytic agents, and we do offer oral contraceptive pills to young girls, of course, with their parents' agreement. So we always see them together and go through this. Sometimes it is quite difficult for some parents to accept that their young daughters are going to be on oral contraceptive pills. And I do sympathize with them, but we have used a lot in our center. And Rezan and I, actually, we have some of our severe von Willebrand patients, we started them with prophylactic von Willebrand concentrate prophylaxis during their early menarche period. But then later on, we have moved them towards oral contraceptive pills. And now I've seen like 25 years of experience in our own center. We have used oral contraceptive pills. And I think Rezan can elaborate more. I have not seen any big major issues at all.
Yeah, I agree as well. And also we have to realize in young girls with severe bleeding disorders such as Glanzmann, severe type 3 von Willebrand disease is not only the heavy menstruation, it's the ovulation, which you can prevent ovulation bleeding, which can be disastrous. So the benefit of oral contraceptive pill in these cases are really well above any disadvantage, and we have to reassure the girl herself, her family, and there is now good data to show that the contraceptive pills that we use now with a lower dose of estrogen in it, and there is no major disadvantage, as Dr. Yisi, and also we always reassure them that this is the period you need it, but when you're older, we could use other other hormonal treatments such as Mirena, IUS, and even when they complete family, there will be other things. So yes, for some of them it's a long period of time. We reassure them data is reassuring, no significant impact on their fertility or any risk of serious disease, and also because they have a bleeding disorder, they're less likely to have venous thromboembolism, which is one of the big issues with contraceptive or hormonal pills.
Okay, thank you for that. Maybe going to the elderly women with a bleeding disorder. We briefly talked about the menopause, but is there anything for elderly women they have to be particular, they know in particular more about when they go into menopause? Is there anything they have to be more conscious about since they've been used to maybe heavy menstrual bleeds, but now they're moving into a different phase of their life? How do we educate them, and what should they know more about the menopause? Maybe Kadir, if you want to start.
For me, Naya, yeah. First of all, the perimenopause, they are not elderly; they are very young. So I don't know what is meant by elderly, right? For perimenopause, we have educated them about possible menstrual pattern abnormalities. So it is okay for a perimenopausal woman to miss a period. It is okay not to have a period for a period of time, but when it comes, it's not heavy, not irregular, not continuous. So that is important. Beyond menopause, beyond 12 months of which we call it postmenopausal, any bleeding is abnormal and should be investigated.
I just want to add one thing, please.
Mm-hmm.
Means Rezan offers endometrial ablation to those women who have finished their family and they were before the menopause if they are having heavy periods, because we have done a lot of a reasonable amount of endometrial ablations in our patients as well.
Okay, thank you. We got a question about the iron levels. Is there a connection between iron levels and bleeding? And could administration of iron supplementals during pregnancy and after birth provoke nose bleeding?
Do you mean to answer, Naya?
Yeah, Dr. Kadir, if you want to start. Yeah.
Yeah, so I think iron is very important, and Dr. Yi mentioned that in the gynecological setting, especially because there is a recurrent bleeding, as well as in pregnancy, because there is an increased demand of iron throughout the pregnancy and growing fetus, growing placenta, and afterward breastfeeding and the rest of that. We start with oral iron, and if it's not working, because some women don't absorb, they cannot tolerate it, we provide IV iron. Apart from advantages and improving patients' hemoglobin and iron stores, minimizing impact of the bleeding of them, there is nothing to worry about. Does not cause nose bleeding. The only side effect with the oral, you have gastrointestinal. Some people feel bloated or stomach upset or constipation. With IV iron is the hypersensitivity or the allergy, and we are mindful of this, and we can of course choose the route that is preferable for the woman.
Yes, I just want to add as well, you know, especially after delivery of a child, you can't be anemic because you've got to be strong and your hemoglobin has to be in a good shape for you to handle the baby and go back home and be, so you need to be strong. So I think correcting anemia is essential. And in the raw-free hematology, we have a pathway for if patients cannot tolerate oral, or if we have to push up the iron in a very short period of time, we do have this pathway to give intravenous iron therapy, which is done in the hospital setting in a ward with full monitoring for all these allergic effects and side effects.
Yes, thank you. In terms of factor replacement therapy, it can be either different factor deficiencies. How often is it that you use factor replacement therapy for controlling the heavy menstrual bleed? Is that only when contraceptive pills are not being used, or what is sort of the criteria for women to get to factor replacement therapy instead of doing hormone treatment, for example?
Right. So let me start off with, so some of our young girls with von Willebrand in the early days when they start Minarche, we have given them clotting factor concentrate. So at the time of the menstruation, together with tranexamic acid. Tranexamic acid is important. So tranexamic acid is started as soon as they start their menstruation, 1 gram, 6 to 8 hourly, and it is continued for 7 to 10 days till the menstruation gets light, right? So, and the clotting factor concentrate for von Willebrand maybe alternate days or whatever. So some of our young girls, maybe 4 or 5 of them in their early stages have gone through this clotting factor concentrate therapy. And then later on, they agreed to take oral contraceptive pills so we could let them go. But of course, we have to remember that if they want to start a family, we have to get them off their oral contraceptive pills, support them with the clotting factor concentrate during their conceivement time. So that is important. So we have done that. So that's for von Willebrand. For platelet disorders, it's mainly antifibrinolytic agents. And we do not want to use platelet transfusion because they can develop antibodies. So it's not an easy thing. So for platelet disorders, because of this ovulation thing as well, we really get them to start oral contraceptive pills very early on. But of course, again, when they want to start a family, we have to come off the oral contraceptive pills and monitor them very closely. So we have done one for a combined factor 5 and 8. We put them on prophylaxis during this early pregnancy and all these things.
So yeah, and if I may also add, I agree with Dr. Yi. We hardly have any girl or women who is on prophylactic just for menstruation as such for a long time. It's for people who want to get pregnant, and also ad hoc for those who are on hormonal therapy as not control. And one has to remember there are multiple agents you can use together. You can use tranexamic acid with contraceptive pill. You can add even Mirena with that. So that way you can control it without the need and the disadvantage of giving replacement therapy.
Or just one thing, desmopressin can be used in some of the symptomatic hemophilia A carriers and some moderate hemophilia von Willebrand patients where they have had a desmopressin response. So we, at one point, we did this nasal spray desmopressin trial even in our center.
Excellent. Thank you very much, Dr. Yi and Dr. Kadir. We will have you on board later on also for some more questions, but we will finish the question and answer session for now. I know we haven't been through all the questions that have been typed in, but we'll get back and have more time for more questions later on. What I would like to do now is to introduce to you all Nurse Malin Svennefalk from Karolinska University Hospital in Stockholm. Nurse Svennefalk has a long time experience with teenagers and also the transition from adulthood into the sort of more general care at the hospital. And she's also very engaged in trying to find more holistic approach to how for women with bleeding disorder, how to cope and which mechanisms to use. So please, Nurse Malin, if you want to give us some perspective on coping mechanism and the role of multidisciplinary teams in managing women with bleeding disorder.
Thank you very much. Happy to be here and to speak about this very important topic. And it's great that there's so many countries involved and share experiences. I'd like to just share some coping strategies through the eyes of a hemophilia nurse with focus on psychological and physical. Focus on preparing for the first period. I believe that a good support early in childhood optimizes even good support towards puberty. That's why it's very important to have the hemophilia centers, you know, and it's even most optimal if you can have the child department close to the adult department. This is the way we have it in Stockholm, in Sweden, where I work. Early information and also a positive relationship between the nurse and the child is very important. And also focus on expecting a positive outcome. We really should be trying to lift forward that there is treatment and we need to work together to tackle obstacles, you know, just to have like a positive thought about this, that we're going to overcome it, so to say. And also we need to be early with the education. Does the child and the teenager feel familiar with her diagnosis? Knowledge keeps the spooks at bay. And if we keep it very, very basic at first and we increase at a comforting pace so that we can feel that the whole family as well is involved. We need to educate the girl, how the blood clots, how the blood coagulates, etc. And we need to focus on the importance of having knowledge about the child's factor levels, if it is a carrier of hemophilia A or B. As the doctor said earlier, that if a child has a lower level, we can expect that she will have a heavy period when she starts to menstruate. Same thing goes for von Willebrand. The level of von Willebrand activity, a girl with severe von Willebrand will bleed heavily, but even the ones with moderate, and we have even mild von Willebrand disease can give a lot of menstrual bleeding. So we have to be observant, and we have to see to it that the family is educated. Also, we have the more rare, like factor 5 deficiency, or we have the factor 10 deficiency, factor 13. There are some more rare deficiencies also. We all need to give them an individual approach, and also our platelet dysfunctions. Next slide, please. We need to educate on how to treat bleeds, and then we have to start early. As we've been saying, tranexamic acid, we use that a lot and always. Desmopressin when we can, when they have milder forms of von Willebrand. And even on carriers it can respond with desmopressin, and it can be given as a nose spray as well. But we would use a lot of Haemate in our patients with severe and moderate von Willebrand, and even carriers with low levels with factor 8 and factor 9 concentrates. We should ensure that the child understands her own personal treatment procedure, and we also need to be individual there, because a young child can have had a very traumatic bleeding if it's a child with, for example, severe von Willebrand, can even have been hospitalized earlier. So as the days and the years come closer to the first period, there will be a lot of anxiety within this girl, and not at all, at least within the mother or the father, actually. I've spoken quite a few times with mothers and fathers who are anxious, and I think many of them are. We should prepare the child to self-infuse if the girl needs factor concentrates or Haemate to treat bleeds, and we should start early with this as well. Next slide, please. We need to feel like a very warm and comforting and supportive place. The patients need to feel that we are here for you, and the child and the family must always feel comfortable and welcome in the contact with the hemophilia team. And a good built-up routine is to treat bleeds early, have medicine at home, at school, and if the child and family do not self-infuse, we need to get help some. If we need to contact Hemophilia Center for treatment, then we need to be supportive and help them. And sometimes I feel that the young girls and even older women have little secret bleeds. Don't stay at home and have this problem. Please get in touch with us and let us know so that we can help you. Next slide, please. I think it's good with a nurse-led clinic for the child and the adolescent girl with a bleeding disorder, because it can be a bit laid back, and the young teenager and the girl can feel, very much can feel a bit at home in that center as well. And we can have education, feedback, and a bit of team building. So at our center, we try to always that the adult nurses meet up with the adolescent girls as well, as often as possible. We need to recognize bleeding episodes before menstruation, like what kind of bleeding problems has this girl had before, so that we can be a bit prepared and help her. Like I said earlier, maybe if she's had a traumatic bleeding, we really need to be supportive here always. And we need to treat the bleed as effectively as possible, and we just need to strive for excellence. We need to have treatment available at home and at the center, and we need to have a follow-up. We need to get the problem sorted. What can we do better, There should always be a follow-up. We should never just, let it go. We should have pep talk as well and offer support all the time. And also have contact with emergency care and other health providers if needed. We've spoken about this already. We all know that heavy periods really can impair quality of life. So we need to keep you can take another next slide, please. We need to optimize the treatment and prevent heavy menstrual bleeding. We need to offer iron substitution, as we spoke of earlier, and keep track on hemoglobin levels. We need to eliminate tiredness. At least this is what our goal should always be, that we offer iron substitution as IV intervention quite often at our center. And also we need to keep in touch with the patient, follow up. And the pregnancy, when they're planning to get pregnant, we need also early support from the hemophilia team, an individual approach, educate and support at an early age. And we need to have a good education and plan the coming delivery in a very delicate way as well. Many women worry about bleeding a lot at delivery, and we need to address this, obviously. And many women worry about having a child with a bleeding disorder. We need to offer contact with the child department, genetic counseling, etc. And we need to really address their anguish, and help them and answer the questions and so on. Our menopause ladies don't complain so much at our center, so I don't have a lot of experience here actually. Most of them, I think many of the ladies have even had hysterectomies, sadly. But I think this is a growing group of patients, and it's interesting and important that we become very open, that we reach and we have open communication, we support and we treat. And we get into contact with the gynecologists who are really the experts here for this group of patients. Also, follow-up is very important. I repeat myself, but it is very important. Thank you. That was my last slide. Thank you very much.
Thank you very much, Malin. Maybe just a quick question. When it comes to, you mentioned this, that you have to educate the family in order, in particular with the young girls, that they are not alone, and the family also needs to know what's happening when they have a bleeding disorder, and potentially also going into a time in their life when they have to manage heavy menstrual bleed. I know Sweden is a fairly open country, but how does the family cope, both the mother and the father? And is there any different reactions from the mother and the father when you talk about that their daughter will have a heavy menstrual bleed?
In Sweden, we're quite a multicultural country as well. So we have patients from all sorts of countries. Sometimes it's a very delicate question, but we have to tackle it. And our aim is always to help the girls, to get them as well treated as possible. I probably think that in Sweden we're using a lot more factor concentrates, like hemate and so on, than in other countries, but even oral contraceptives. But of course, it's still important with the open discussion. And also to speak to the young girl by herself as well, and to explain that this does not mean if the young girl or the young adolescent needs contraceptives, oral contraceptives, if they bleed a lot and they can't self-infuse, or if that's a problem for them, then we need to be very, very, very clear and explain that this is because of your bleeding disorder. It doesn't mean that you're sexually active, and we need to explain that to the parents as well.
Thank you very much for that. To what extent do you, when you talk to education, to what extent do you work with the patient organization? Is that somebody you align with in order to find out how to communicate with the patient group?
Excellent question. Definitely this is something we need to work a lot more on. I know that my colleague has been in contact a couple of years ago, Petra, with the patient organization, and is very active in this women with bleeding disorders organization. I think we can do a lot more, actually. Even if we're a country that we've come a long way, we can still do a lot more, and we need to reach out a lot more. And I think we should be having groups of teenage girls getting together, having discussions. And now there's sadly Corona situation, but there was a planned women meeting, would have been now this spring here in Sweden. So definitely, but there's more work to do, and I think that's a very good place to do it in. Excellent.
Thank you very much. I think I'll open the floor now for some more generic questions. I can see that there are coming a lot more questions in. So I actually have a question for Dr. Kadir. Sort of what is your experience with platelet disorders and IVF in terms of if a person with a platelet disorder who has a long record of endometriosis and heavy bleeding, what are your sort of advice, or what is your experience with going into IVF with platelet disorders?
So, yeah, thank you, Naya. So actually, as we know, majority of platelet function defects are mild or moderate in severity. So the severe ones, such as Glanzmann's thrombocythemia and Bernard-Soulier, they are rare, and we have not had any case that needed fertility treatment. But for the rest of majority, it's counseling about the risk of bleeding and treating mostly with tranexamic acid and liaison between the fertility team, the hematology team, and the rest in case any bleeding complication happen. And I think most of the cases, and Dr. Yi will probably hear and agree with me, that tranexamic acid, whether oral or IV, depending on what process we're doing, will be sufficient for this mild platelet function defect. For the severe, like Glanzmann, it's a different issue. I think we have to probably, and we have not had any experience with those cases needing fertility treatment. I think some of the invasive procedures, such as ovum retrieval, may require, maybe platelet infusion or other issues. I mean, we have even used recombinant 7A in cases of severe platelet function defect that has been at risk of bleeding during menstruation, for example.
Right. So can I just add a couple of things? So these patients who have Glanzmann, I think before they get married, we have to counsel them to make sure that they don't also marry close family members, because we don't want, so that is very, very important. Because for our factor 11 patients, when they come, we have to measure the factor 11 of the partner, so then we know that the offspring will have severe factor 11 or whatever. So in these platelet, although they are rare, if they marry within family, there can be a chance of their offsprings also being affected. So I think this is very important as well for them to understand. The second point is we have not actually practically manage a Glanzmann with infertility, but as Rezan mentioned, I think during the egg retrieval, we would consider using recombinant 7A or HLA matched platelets. So platelet transfusion also has to be very clear, HLA matched platelets, because if they need platelet transfusions frequently, we've got to make sure that they are not developing antibodies. So that's how it will be.
Maybe also we have another doctor standing by, Dr. Roseline. Maybe if you have any experience with platelet disorder and IVF, if you have any comments that you think could be relevant to put into this discussion.
Yes, good afternoon, everyone. Thank you very much for this opportunity. I think that was really very interesting presentation by 3 of your speakers, so really that was great. Regarding the use of IVF in Glansman patient, we had a little experience because, as Rezan said, these patients are extremely, a very low number of patients actually who have this situation, and a low number of patients are in the menstrual age and the pregnancy age, and only very few of them will attempt maybe to get a pregnancy. I think there is one concern regarding the pregnancy in Glansman is the immunization against platelets, because for those women who have anti-2B3A antibodies, which are the antiplatelets antibodies that develop in Glansman thrombasthenia patients when they receive platelets, not all of them, but at least maybe something like 30% or 50% of them, it depends on the mutation that is responsible for the Glansman. But for those who have such kind of antibodies, we have to be aware that these antibodies may cross the placenta and destroy the fetal platelets and be origin of complications, loss of pregnancies. So the experience that we have in France regarding those patients, because we have a quite large community, a gypsy community, and a lot of them are affected by Glansman. So we had a few of them that went through that process. We really have to be very careful before we move on to such kind of a procedure, that we are dealing with some of those patients who do not have currently available detectable anti-2B3A antibodies. Unless we do have such kind of antibodies, it might be extremely risky for the mother to secure the bleeding during the delivery. And it could be potentially as well extremely difficult as well for the neonate or the fetus, because they may destroy the platelets of the baby, and that could be through this transplacental transfer of these antibodies, they may lead to thrombocytopenia in the fetus. So that is really a very complex issue. However, we have some potential possibility to overcome that problem and to potentially try to limit the risk of this transfer of those deleterious antibodies by giving immunoglobulin to the mother on a regular basis, high doses of that. It is not that simple to do. There are also some side effects. So it is accessible, but really for a limited number of patients with Glansman, and it must be really very well balanced with the potential risk. So it needs really both a preliminary evaluation from the obstetrical point of view, the hematological point of view, and the patient's point of view. That's what I could say.
Excellent. Thank you very much for your input and that you took the time as well to be online today. Maybe a question for Dr. Yi.
Just one, if I can.
Yeah, sorry. Please go ahead.
Just to have a positive talk and words, we did succeed to have some pregnancies in Glansman patients through that process. So I think that's important to know, even if it was not all of them, of course, but we did have some successes.
Thank you. I think that was a very important conclusion on it, indeed. Thank you. Dr. Yi, I have a question for you. Do you think that we should make risk assessments for thrombotic complications when prescribing hormonal therapy to regulate and manage periods for young women?
There are lots of women who are taking oral contraceptive pills with normal hemostasis, and very few come up with thrombosis. Now, this cohort that we are treating are patients with bleeding disorders who have who have less risk for thrombosis. So we do not routinely do thrombophilia screen, or of course we advise them on lifestyle, to make sure that they do not, they avoid dehydration, if they are heavy body mass index, to lose weight and lead a healthy lifestyle. But we do not routinely go through the thrombophilia testing. But you have to remember, the patients who have heavy periods are those with severe bleeding disorders who have very low risk for thrombosis.
Thank you. A question for Dr. Kadir. Maybe if you could elaborate on some of the symptoms that should be taken into account in case of ovarian cyst rupture or ovulation bleed in order to avoid misdiagnosis by a GP or a non-bleeding disorder specialist.
Yeah, thank you very much. So as I mentioned, that most of women will have some women with bleeding disorder mainly describe some pain mid-cycle, anytime between day 12 to 17, 18, and it's usually manageable. But these are the ones who have a recurrent. It's not only once a year. They keep repeating that. These are the ones we should be careful about. We should investigate at the time when they have a bleeding, because bleeding after ovulation can easily be diagnosed with a pelvic ultrasound. And these are the ones who could lead sometime as a bigger bleed. And these patients should be counseled about that. And really, the only solution is combined oral contraceptive pill, because combined oral contraceptive pill or combined hormonal contraception are the only method that helps menstruation, but at the same time suppresses ovulation in 100% of the cycles. While others, Mirena IUS, which is a hormonal coil, or a mini pill, which is only progesterone, or the implant, could help the menstruation, but it does not suppress ovulation in every cycle. So that is important that we educate them about that. And of course, as well, I want to add the severity of bleeding disorder is important. Those who are severe, we start at the beginning, from when they come before menarche. We educate them about this possibility, educate their family, and as I mentioned, and Dr. Yi mentioned, we start the pill even before first menarche to avoid such bleeding.
Thank you very much. I know all three of you you're working with the women who are already diagnosed, usually with a bleeding disorder. But we actually got a question in this area where it said, well, we have many, like the patients you see, a lot of them with severe bleeding disorder, they have been diagnosed a bit earlier because the symptoms probably have been more severe. But would you have, maybe Malin, if you want to start, do you have any recommendation on how to make sure that the ones who might not be as severe with a less severe, mild or moderate bleeding disorder, how we become better at diagnosing them so you can actually make sure that they get that care? Malin, if you have some idea about that?
I think there's a large amount of women and young girls out there that haven't been correctly diagnosed. I think that's the question. We get a lot of referrals regarding these girls, and I think it's very, very important that if you have a bleeding disorder, preferably to a specialist center if you can, and see if one can get a diagnosis, because correct diagnosis will lead to correct treatment. So it's very important. And even if sometimes we don't find any diagnosis, but we can still help anyway. We can. One can try tranexamic acid, and we can always do something to help these young girls and ladies.
Yes, Dr. Kadir, you are muted. So here you go.
Yeah, I was just saying that although I work within the hemophilia center and I see patients with already diagnosed, but I have the gynecology and obstetrician hat where I see women who comes for a general obstetric and gynecology, and I see a lot of women who are undiagnosed. And I think we can only get the diagnosis for majority of women of the mild and moderate, because they suffer as well, is through educating the wider community, patient, being families, as well as other clinicians. Of course, it's easy for a hematologist to think about bleeding disorder and diagnose it, but it's important that the family physicians and a gynecologist think of the bleeding symptoms that is possible to be underlying the gynecological or obstetric bleeding.
Thank you. Dr. Yi, do you have any input on this one?
Of course, I do see patients who are referred to me to get a diagnosis of bleeding disorder. So I do make a diagnosis of mild and moderate bleeding disorders. But what I want to just emphasize is for the general public is that whoever has heavy bleedings, please go for antifibrinolytic agents, tranexamic acid or aminocapric acid, and iron therapy. You will not go wrong, even if you do not have an underlying bleeding disorder. This will help you a lot and also lift your moods and spirits up when you are iron replaced and your hemoglobin is not low. That is very essential.
So Naja, may I add as well? I think I really completely support that every woman should be diagnosed, even if it's mild, before we treat them. And I think there are simple tools. Awareness is important, but teaching clinicians, general practitioner, gynecologists, and everybody to use two simple tools, and they will pick up majority. The bleeding score that Dr. Yi mentioned, and there are good criteria how to do it and what score you should refer, and menstrual score. So these two simple tools, if we educate our clinicians, nurses, doctors to use it, I think we will pick up majority of the women.
Thank you. And maybe if I could say for another question for you, Dr. Kadir, are women with a bleeding disorder at higher risk at miscarriage during pregnancy, or can there be any damage within the uterus for women who had a bleeding disorder and potentially also experience a lot of endometriosis that could lead to miscarriage or issues with pregnancy? It's a little bit two questions in one.
So there are only two bleeding disorder which we know for sure that causes a miscarriage: severe fibrinogen deficiency and factor 13 deficiency. Well, these are two bleeding disorders that there is evidence that is associated with increased risk of miscarriage in early pregnancy, and there is some evidence that the pregnancy cannot continue without replacement therapy. And also later on, they could even lead into premature babies, intrauterine death. These are the two. With the rest, we don't have any evidence. It is difficult to say, and there has not been a good study to show that. There has been case report, but if we think about it, miscarriage is very common in the general population. So it is difficult to know. For sure, my experience, more than 20 years, I don't have a feel that mild von Willebrand disease and in carriers there is increased risk of miscarriage. Whether the severe ones have increased, but the severe ones, as Dr. Roseline said, very few we see. So it is difficult to say. We have one case. She had a severe von Willebrand disease and she miscarried repeatedly. But we didn't know why she was miscarrying, so we did everything. We gave prophylaxis during early pregnancy. We put a stitch. We gave her progesterone support. So we empirically tackled every angle, and she now has 2 successful pregnancies, two boys. Yeah.
Very good.
So I just want to add as well. So a lot of our von Willebrand patients have conceived naturally, and we have not given them prophylaxis. But in the case that I was mentioning earlier on, the honeymoon disaster, because she's infertile, and this is precious baby, so there is ovary retrieval. So I'm covering her with clotting concentrate during this retrieval, and also during the embedment when you introduce the fertilized ovum again. I am covering because I want good hemostasis, good embedment. So in certain cases, of course, we will provide support. But I have come across patients who were not on prophylaxis and conceived naturally. But in special cases, we will support their hemostasis. That is important.
Thank you very much. Maybe for a last question, I think you could potentially start, Malin. When you have young girls at your clinic, some countries say that they are not allowed to talk with a young girl without the parents' approval. Do you experience issues like that, or is it easy to get the parents' approval in terms of talking with the young girls on your own?
I've never experienced that. I think maybe if you ask the nurse at the child department, maybe there's a bit of a problem, but otherwise I would say no. If you do it in the right way, because most parents want the best for their child, and if they understand that this is just, they will probably feel that the child is in safe hands. They need to feel that my child is in safe hands, and then I don't think it ought to be a problem. I've never experienced it. On the contrary, it feels like it's a bit of a build-up for the child. So I wouldn't say that this is a problem, no. Not from my experience.
Dr. Kadir, do you have any experience with the young girls and talking with them on their own, or the parents always are present?
No, I think I agree with Malin. We don't have. I think it's all about talking to them and making them trust you and trust the team, and also building the relationship. For us in the Hemophilia Center, we've gone through from the childhood all through to menopause and beyond. So it's this trust between us, and we have not encountered any difficulty like that.
Can I just add one thing, please?
Yes, of course.
Yeah, in UK, before the age of 16 years, you are termed a child. So for clinic attendances, a parent can go along, and a parent usually goes together with the child. But once you get to 16, the parent cannot go along with the child, and the child is seen by the clinician on their own. So that's the rule in UK.
Yeah, but often you can ask, and I have done, because being a gynecologist, wanting to ask sensitive questions, ask the mother, do you mind leaving the room? And I've never had any proper difficulty. And the same token that the girls don't mind. They said, we're open with our mother, so majority of cases are absolutely fine.
Perfect. Thank you very much, Dr. Kadir, Dr. Yi, and Ms Svennefalk for doing your presentations, and also be available for all these different questions going in different directions. We are very thankful for that. We are about to close this webinar, so I just want to say thank you to our sponsors again, Bayer, CSL Behring, Novo Nordisk, and Takeda for supporting this event and the community. And not least, I want to thank all of you who joined this webinar today. It was a pleasure that you wanted to stay here for 1.5 hours. Before you leave, I just want to remind you that the EHC Women and Bleeding Disorder Committee has started a quarterly newsletter that you can sign up for the EHC website, which will be potentially useful to all of you who have an interest in women with bleeding disorder. And you can also, of course, find more about all the EHC activities on the social media. And with that, I just want to say thank you again to everyone, and I hope to see all of you again tomorrow for a second webinar about the place of women in comprehensive care, which starts at 10 a.m. Central European time. And with that, goodbye, have a good day, do svidaniya.